All right, everyone, we're going to go ahead and get started to just be mindful of the time. We appreciate everybody joining. I'm sure there's going to be some other people joining as things get rolling. But we've got a didactic presentation, also a case presentation. We're going to start with the didactic first from Talisha Franklin. Talisha, I will share the screen. I have your slides. If you'd like me to advance them, you can just tell me when to do that, and or if you like to control them yourself, that's totally up to you. I just need to know to make you a co-host, whatever you prefer.
Either way, you can advance them, that's fine.
Okay, just give me 1 second then, and we will get things rolling. In the meantime, I'll say one more time just before we begin, for those who are just popping on, please introduce yourself in the chat, your name, your email, your organization, and credentials as well. That'll be used for CE purposes. All right, give me 1 second here. All right, everybody able to see the slides? Okay, you're seeing some head nods. Thank you very much. Take it away, Talisha. I'll forward them when you need.
Okay, thank you. Hey, everybody. My name's Talisha Franklin. I'm the nurse manager for the neonatal therapeutic unit at Cabell Huntington Hospital at Hoops. And I have Courtney Wellman with me. She's our nurse practitioner for the MOMS program. We actually did this presentation together during the last ECHO session. So she's here with me too. So at the end can answer some questions. All righty, let's go. We're going to talk about breastfeeding and MAT. We all know that breastfeeding is beneficial, so we're going to talk about the generalized benefits of breastfeeding. Infants breastfed in their first 3 months of life are 23% less likely to develop ear infections, 65% less likely to develop GI issues, 58% less likely to develop necrotizing enterocolitis, also known as NEC, and 36 to 50% less likely to be a victim of sudden infant death syndrome, 15 to 30% less likely to develop childhood obesity. Okay. Go right ahead. Breastfeeding infants with NAS. There are many benefits to breastfeeding infants with NAS that extend beyond all the benefits we just discussed previously. Part of that is the increasing the maternal-infant bond, a shorter average hospitalization admission, lower NAS scores, slower onset of the symptoms, reduced pharmacotherapy requirements, and shorter duration of the pharmacotherapy treatments. Next slide. The maternal benefits of breastfeeding for everyone, but specifically to those participating in medication-assisted therapy, are a higher treatment retention rate at 12 weeks, postpartum, which is 35% higher, enhanced maternal-infant bonding, decreased risk of postpartum depression, feeling more involved in their baby's care, decreased sense of helplessness, and the mom being able to feel like she can do something for her baby that no one else can do. Next slide. The two most common medications that are used in MAT are buprenorphine and methadone. The mechanism of action of buprenorphine is partial opioid agonist. Methadone is a full opioid agonist. The oral bioavailability for buprenorphine is 10% and 70 to 80% for methadone. The conversion process for buprenorphine is difficult, while with methadone it tends to be a little bit easier. Let's see. The buprenorphine is prescribed weekly, methadone is daily. Overdose risk for buprenorphine is less, not zero, but not common. Methadone has a greater risk of overdose. The NAS risks are the same. The NAS duration It's shorter with buprenorphine, a little bit longer with methadone, and but both are safe to breastfeed. Both choices. We prefer at the Moms Program, we use buprenorphine, but even our moms that come in that go to the methadone or have methadone for their MAT treatment, it's still safe for them to breastfeed. So we encourage them to do so. Next slide. Buprenorphine and breastfeeding. Women who receive buprenorphine treatment for OUD during pregnancy should be encouraged to breastfeed their infants if there are no other contraindications. Infants with mothers taking buprenorphine receive less than 1% of the maternal weight adjusted dose through breast milk consumption. The poor bioavailability of buprenorphine when taken orally means it's unlikely that significant absorption will occur from the breast milk. Women taking buprenorphine or naloxone should also be encouraged to breastfeed. While there's no human safety data available, neonatal effects are unlikely based on the limited bioavailability. Next slide. Methadone and breastfeeding. Women who receive methadone treatment for OUD during pregnancy should also be encouraged to breastfeed. Infants with mothers taking methadone receive 1 to 3% of the maternal weight adjusted dose through the breast milk. Neonatal plasma concentrations of methadone are not dependent on the methadone dose. Though extremely rare, they could be monitored for respiratory depression and other symptoms associated with opiate exposure. And it is recommended if a mother is on methadone that she not abruptly discontinue breastfeeding, but rather wean the baby gradually. Next slide. Patients who are positive for HCV should also be encouraged to breastfeed, but they should be educated and monitored for cracked or bleeding nipples. If they do have cracked or bleeding nipples, they need to be educated to pump and dump until they're healed. And they can continue to breastfeed on the unaffected side. And then when they are all healed up, they can continue as soon as possible. Next slide. Patients who are positive for HIV, the CDC and American Academy of Pediatrics consider this a contraindication and recommend avoiding breastfeeding regardless of the antiretroviral therapy or the patient load. In countries like America, I mean, where we have clean water and other resources, it's an absolute contraindication. They should be educated of the risk should they choose to breastfeed, and have some emotional support readily available to them to discuss that further. Next slide. Can patients positive for HSV breastfeed? The best recommendation from the CDC is maybe. Women with herpetic lesions may transmit to their infants if they have direct contact with the lesions. It is acceptable if there's no lesions or outbreaks, but it's contraindicated if they do have active lesions. Mothers need to be taught good hand hygiene and cleaning their pump and their parts in between each pumping session, and assess themselves before each feed for lesions. Next slide. What about mothers positive for THC? This is a biggie for us here at Cabell Huntington Hospital. American Academy of Pediatrics says that THC exposure is a contraindication in breastfeeding. However, there's insufficient data to say whether it's safe or unsafe. Like I said, it's our policy that mothers who are THC positive are not permitted to breastfeed. Chemicals from marijuana in any form can be passed from mother to infant through the breast milk. The chemicals have potential to affect a variety of neurodevelopmental processes in the infant. THC, which is the main component in marijuana, is stored in body fat and slowly released over time, meaning the infant could be exposed to unknown amounts for an extended period of time. Some products, including CBD products, may contain other contaminants such as pesticides, heavy metals, bacteria, and fungus that could be dangerous to a mother and her infant. Next slide. Data on the effects of marijuana and CBD exposure to the infant through breastfeeding are limited and conflicting. To limit potential risk to the infant, breastfeeding mothers should be advised not to use marijuana or marijuana-containing products in any form, including those containing CBD, while breastfeeding. Mothers should also be educated on secondhand smoke exposure. Marijuana use may also impair a mother or other caregiver's judgment and ability to care for their infant. If a mother continues to use marijuana or CBD while breastfeeding, she should be encouraged to significantly reduce her intake. Next slide. Barriers to successful breastfeeding is stigma. That's a huge one. A lot of our mommies that come in, they feel judged and feel like they're doing something wrong because they want to breastfeed their babies. So anything we can do to overcome that stigma and encourage those mommies is definitely what we should do. Patient education deficit. Some mothers still come and they don't know that they're allowed. I hate using that word, but they don't know that they're even able to breastfeed because it hasn't been discussed with them prior to delivery. They get conflicting information between OBs, pediatricians, residents, nursing staff, and it's very confusing and overwhelming. There's a lot of misconceptions about whether or not MAT is safe when breastfeeding, and there are a lot of physicians, even here in our facility, that disagree on this topic. Policies in place. Our policy is if you have 90 days of consistent screens in your MAT program, you are permitted and encouraged to breastfeed. Next slide. Babies with NAS are more difficult to breastfeed. Some barriers include increased irritability compared to infants that are not prenatally exposed to substances, uncoordinated suck related to NAS, more difficulty latching and staying on the breast, lower average birth weights, excessive sucking or weight loss related to NAS could prompt nursing staff or pediatricians to supplement with formula sooner. Sorry, couldn't get it out. Sooner than they typically would recommend for a baby that wasn't substance exposed. Next slide. Breastfeeding is hard. It's hard for everyone, and it's especially hard for our mommies with substance use disorder. It's even more difficult when the following are present: when they have a lack of support from their family or significant others, when they're unable to understand or read the infant cues, if they're not able to room in with their infant, if their infant is moved to another area, such as NICU or NTU, if they're not able to room in, feelings of hopelessness, guilt, or shame, if they are diagnosed with postpartum depression or have a history of sexual trauma, which is incredibly prevalent in our population. Next slide. So what can we do to help? If delivery is scheduled, it would be so helpful if you would send your patient to the hospital with their last 90 days of screens. A lot of times they get here and we say, yes, we want you to breastfeed, but we need your screens. And if it's on the weekend, sometimes it's hard for them to have access to that. And so by the time they're able to get it, they're 3 or 4 days out. And by then we have definitely decreased her ability to successfully breastfeed. We want to educate our patients, let them know that their rights and that breastfeeding is safe on MAT, and that and it is their right to breastfeed their infant. Let her be her own advocate, armed with knowledge of her rights as a mother in recovery. We can offer a breastfeeding grace period for our moms, like we were talking about the screens. If they come on the weekend, they don't have access. And she states that she's been successful in her program for weeks or months. If we can give her a grace period to allow her to get her hands on those screens so she can go ahead and start the breastfeeding process. The first 24 to 48 hours of breastfeeding are crucial. Do not let a mother lose those precious hours. Just give her some grace. Next slide. Some more things we can do when we visit our patients in the hospital room. We always try to ask how your breastfeeding is going. So hopefully they will open up and share some concerns or barriers that they're experiencing. Also, we can place a consult to the lactation consultants and ensure the patient is aware that they're coming so they can be prepared with questions. Use breastfeeding signs on the patient room so that providers and other staff members know to knock and wait for a response prior to entering. Ensure the mother is aware of lactation consultants who are trauma informed. Allow the mothers to room in with their infants if at all possible and offer them privacy when nursing. And encourage patients and let them know they're doing a great job. Next slide. Does anybody have any questions? Do you have anything to add, Courtney?
No, it was good.
Thank you so much, Talisha. That was great information. I wanted to ask a little bit about your experience. It is our experience too in Morgantown and other hospitals that we interface with, that patients get misinformation, or they have multiple providers telling them different things about what they are supposed to do, are allowed to do, are not allowed to do. How do you guys try and help patients navigate that or educate providers? Any suggestions on that?
So the main thing that we do is just to make sure that our patients are well educated on their rights. We let them know the statistics for what is safe in breastfeeding, for the benefits of breastfeeding on MAT, and the benefits to patients who have NAS. We verbalize to them that we understand that maybe their pediatrician has told them different information, but we tell them that our information comes from the American Academy of Pediatrics, and that per our policy, this is what they are allowed to do. We hate to use that term allowed because at the end of the day, this is their baby. And if they want to breastfeed, they can breastfeed. So typically that's what I tell them and hope I don't get in trouble.
We want them to feel empowered to breastfeed though, because there is a lot of stigma associated with it. And so they feel bad, almost like they're doing something wrong because they're breastfeeding. And we just really want to change that outlook that no, you're doing something amazing for your baby because you're breastfeeding. But even in our physician population, we do have a lot of discrepancies. So just education is really all that we can do in helping our mamas feel empowered.
Yeah, which is why I was super excited you guys were doing this echo. So thank you for being here.
Good. Anything else?
So I'd like to ask if anyone else on the call is from another health system, if there's been any other barriers that you've noticed with implementing breastfeeding in this patient population.
Don't be shy now.
I was going to point out something else that it's funny, not funny, of our THC population. Our breastfeeding rate is about 90% in that population, which of course that's contraindicated from the American Academy of Pediatrics, and we recommend that people don't do it, but it's just a total blind eye turn toward it. But then our moms in our MAT programs, with their prescription medication doing well in recovery, it's like it has the exact opposite effect, if that makes any sense.
I think that's really well said, and great job, Talisha. The differences with marijuana versus MAT. And as you know, it's really hard with our population that are hardcore, marijuana users. It's very hard to, if not impossible, to convince them that this is not a great idea with breastfeeding. So they need a lot of education too. And And I really encourage folks to document that, you know, until we have more data. We're just, you know, not, it's so hard to say, you know, and I'd love to be wrong. But when we look at medication safety, you know, marijuana has those things that we look for as far as, you know, it loves fat. So it's going to go right in the breast milk and it's going to go to those vital spots in baby. Question is, what is that going to do down the road? So really talking about, you know, risk and benefit there, that's important too. About your question, Laura, about experience in other healthcare systems, when I've worked with folks around the state, I will periodically, I'll get emails from different hospitals and say, well, we have this one pediatrician and they just will not let this mom breastfeed and she's doing great. You know, and I look at it as it's a reward for them, you know, so much of the time when they've done well in treatment. And like you said, educate our moms. The policy is huge, and for it to be clear, and the hospital sets that policy, you know, but then there's the piece about, you know, educating the provider. And we do have a lot of good references on that. And through the Perinatal Partnership and the Breastfeeding Institute, we're happy to share those. If you've got one of those hardcore providers that you're working with and not able to convince them, you know, as well as your administration, and need a sample policy.
That's great, thanks. I was wondering, does anyone have any general questions more on the patient side as far as how to answer their questions or troubleshoot any issues that our patients in recovery have had with breastfeeding?
So I was just going to bring up the thing I often hear, which is, and that patients are told by other providers, is that they will benefit from the medication in the breast milk. And you guys showed kind of the statistics on that, specifically for buprenorphine, the bioavailability being very, very low and the amount being very, very low. But again and again, they hear that, and maybe they're hearing, you know, maybe what's being said is actually breastfeeding will be of benefit versus breast milk will be of benefit. And that's maybe a distinction that can, you know, we continue to educate moms on and providers on. Like specifically breast milk with medication is not the benefit. Breastfeeding and generally breast milk being the primary benefit.
Yeah, I think that's an important distinction too. We have moms that think that as well. Thank you guys for your time. Any other questions?
I didn't have a question, Talisha, but I wanted to say I really like in your benefits list, you had said that it's something that the moms can do that nobody else can do. And I think that is so empowering for our moms. I hear from so many of our moms saying, you know, I want to be the best mom. I want to do the best possible. And I feel like that's huge for them to accomplish that. And it's definitely detrimental sometimes for moms who are looking forward to it that are not able to do that.
Absolutely. We work really hard from our end over here to try to make sure that everyone is able to breastfeed, has that opportunity if they want to, and help them overcome barriers so that they can form that attachment.
I do have a question, Talisha. I'm just thinking of someone that this has kind of happened recently. She relocated to the area for treatment from another county. And so I'm not sure at delivery whether we already had her UDS screens from when she was in treatment with her previous prenatal care provider. What kind of advice would you have for someone in that situation?
This is a perfect example of what we try to overcome before delivery. If we're able to speak to moms like in the MARC program or in the OB offices would be, ooh, that would be wonderful, wouldn't it? But just letting them know if they do transfer in the middle of their prenatal care, like to put the responsibility on them to bring their screens, because a lot of times the OBs, when they send them for induction or delivery, you just get that one page, like 37 weeks, male, just really generic. And sometimes they list substance use disorder in their treatment and sometimes they don't. And so if the mom isn't able to prove herself with her 90 days of consistent screens, then a lot of times right off the bat, it's just, oh, nope, you don't have your screens, you can't breastfeed. So she never gets to put that baby to breast to begin with. And by the time they get to me or Courtney's seen them or we get involved, it's like 2 or 3 days later and we've missed that window of opportunity. And also the moms feel defeated and, you know, they're saddened by that because they wanted to breastfeed. But I do feel like educating the moms ahead of time would be the best way, and you know, put it on them, like don't rely on your physician to get these to us before you deliver. Make sure you have them in hand.
I appreciate that. Is there anything that you've noticed with moms in this population, like any particular difficulties they're having? This is more anecdotal. I know you addressed it in the presentation, but as far as latching or the amount that they're able to pump or anything like that?
I think mainly, this is Courtney, by the way. I think latching is the big one, and people are not great about putting in lactation consultant orders. So I will do that when I see them. But also the biggest barrier is still just education, but we also have issues with their sexual trauma as well, because we're not great as a healthcare whole at identifying patients who have had sexual trauma. So it's nothing for us to just knock on the door and walk in, and you know, it's not a big deal to us to see a woman with her breast out breastfeeding her baby, but it might be a big deal to that mom. And then if we're re-traumatizing her and triggering that PTSD she may have from the sexual trauma, then that already throws up a huge barrier and makes it way more difficult for her to be successful.
Yeah, I'll add in terms of the kind of stress, which, you know, interferes with the letdown and a lot of the processes involved in breastfeeding. Sometimes just the stress of seeing their baby, you know, exhibit signs of withdrawal, or knowing that they're going to be dealing with, you know, some stressful interactions coming up. Sometimes I think can interfere with mom's ability to relax and to be able to either pump or feed at the breast.
Yeah, 100%.
Courtney, do you provide, or I'm sure you and Talisha provide some resources around that sexual trauma and breastfeeding, but when it comes to, I know that some women in trauma have reactions to the feelings of letdown or the hormones that result in those, and the sort of anger or anxiety, or all, like, I know that there can be a whole variety of emotions that sensation can trigger. Do we have some good resources for that? Because I'm thinking that would be great to share if we did.
I actually don't. I mainly just discuss it with the patient and make sure that she feels comfortable speaking to someone, and try to ensure that her primary staff is informed and know how to respect her privacy, and let the patient know, you know, it's okay to tell people that you don't want to be seen right now, and give her that power. But in terms of actual written materials, I don't have any that I know of.
No, we don't, unfortunately. That might be something good to look into for sure.
Did a quick search while we were right after I asked the question, and honestly, I'm literally embarrassed by the dates that are coming up on anything that's on the internet. I don't think I've Googled anything recently where a date comes up with 2018 as being my top 3 searches. So once again, women's issues around this topic not being in the forefront of things that people are producing, but something that it sounds like there's a significant gap that needs to be addressed.
For sure.
All right, any other questions? All right, hearing none, we can move forward. Jay, can you put up our case presentation, please? All right, so I will hand things over to Amanda Newhouse to give us a case presentation that we can all discuss as a group.
Okay. Hello, everyone. So the case I presented today is one based off of some trouble that I had with a patient who was really wanting to breastfeed and trying to. Just want to check in real quick. Can everybody hear me okay? Okay, perfect. I didn't check first, so just making sure. So the general assessment, this was a 30-year-old female with a history of substance use disorder and depression. She herself was adopted as an infant and did some great work around that. She was in and out of mental health treatment throughout her life. She's been in the medicated assisted treatment program with WVU Medicine since 2018 as a step-down referral from residential. In January of 2021, her treatment intensified some after a relapse to IOP and then returned to outpatient in spring of 2021. In June of 2021, she delivered her little boy. He had fluid on his lungs and he was jaundiced, so he was taken to the NICU right away, and she was not able to see him. She really was trying to advocate to go see him, and they insisted that she take care of herself first. But she was able to see him for a 30-minute period of time over 24 hours. So she felt like she really wanted to see him more, especially right after she was planning to breastfeed. So when they found that out, they came in and they asked her to pump without seeing him. And she has had other kids and she's like, I don't know how they want me to pump without seeing my baby. So she really struggled with some of that. She advocated and demanded that she see him. And once he was medically stable, then they brought him into her room and she began to breastfeed then. So she breastfed then for about 28 hours. And then the doctor had insisted that she stop because of the buprenorphine in her system. And it was prescribed. So she tested negative for everything except her buprenorphine. And so he insisted that she stopped until she received a letter from her prescriber, and she did right away. We advocate strongly for breastfeeding, and so we have some of those resources on hand as well. And so I was just thinking as we were talking about that, and Jay, I hate to put this on you, but Molly had shared that she has some resources that she sends out, and maybe we can combine our resources. Maybe we can send some of the resources we have, and Molly sends some of the resources she has, and maybe we can go through that, not to duplicate, but send out some of those resources. I think that would be great. But we did provide a letter with some resources involved, and she was able to start breastfeeding again. In that time frame, though, he did have 3 bottle feedings that he was not able to keep down. He was losing weight, he was throwing up. And then she started breastfeeding again. And then CPS had come for their visit. And because she had had previous removals, the baby was going to be placed into foster care. And she knew that. She prepared for that. But she was able to permitted to feed him breast milk until the milk that she had pumped had she depleted all that, but she wasn't allowed to breastfeed until discharge. So CPS was allowing her to use the breast milk, but not breastfeed, which, she was uncomfortable with too. And then once he was removed and in foster care, she really wanted to provide breast milk, and they refused her of that too. So this was a case I felt awful for this mom, and she was really doing a great job of appropriately advocating for herself. We do have a centering program at WVU Medicine. I think we mentioned this a couple of times, but our centering program has a midwife, a peer recovery coach, drug-free moms and baby coordinator, our therapist, our prescriber. And so we were all able to advocate for her, but she was advocating for herself really well too. And so we didn't have to do a whole lot. We did provide her with some resources, but I'd really like to know what others do to advocate for your patients in these situations, and how we can advocate more, or maybe be more prepared for something. I mean, this one threw me completely off. I mean, even not being allowed to even provide, I've had a lot of patients be able to provide breast milk still, as long as it was appropriately handled. And so, I struggled with this one. I struggled with how the baby struggled when he was taken off of breast milk. And so, and even the baby was returned to her. It was 6 months, the baby was returned to her. And she didn't start breastfeeding then because he had finally adapted to the milk. And she was so fearful of, those 3 bottle feedings that he was throwing up and not keeping anything down. She really didn't want him to regress in his growth and development. So she was even fearful to go back to breastfeeding. So it really kind of created some fear on her end too. So I just wanted to kind of reach out to everybody and see what everybody does as far as advocating for these situations.
I have just one clarifying question, Amanda. Do you know, was there any medical reason they didn't want her to feed at the breast, like, a transmittable illness or anything like that?
No, there was none. Yeah, there was no medical illnesses that there was a concern of.
That's a great question, Jen.
It is.
That to me says knowledge deficit on the part, of someone, and so much is both milk, but also mom.
Right.
I think we're all on the same page. Mom is medicine.
Right.
So,
right.
yeah.
And she was one of our patients that was like, it will help with NAS because he'll get my medication through the breast milk. And I was like, no, it helps because you're holding him and you're bonding and you're attaching and you're soothing him. And that's what really helps. And so even when we provided her with some of the documentation, we went over what it was included in that. Our midwife did a great letter, and then we went over what was included in that. And she was like, oh, she's like, this helps me even more. So it helped even, gear her up for advocating for herself too. So, yeah.
I feel like that was an excellent case study to choose, because I feel like, unfortunately, that happens, I would say, nearly daily here. It feels like they go to the NICU, they're separated, they tell the mom what you just said, don't worry about the baby up here, you take care of yourself down there. And that's agonizing for the moms. And then, like you said, you don't get your milk production coming in, you can't get that sense of letdown, you're nervous. But unfortunately, I feel like that happens way more often than we would like to see. When we find that out, Courtney and I both are really, we have great relationships with all the staff and stuff, and we'll go and say, oh, this is one of our moms, she's doing so great, let's really encourage her to breastfeed. And a lot of times just having those in-person conversations can turn they're busy, they're not worried about messing with it, they're not worried about getting her a pump. But if you just go up and say, hey, this is one of our moms, she really wants to breastfeed, can we help her? It seems like that can turn it around, and they start like, oh, okay, well, I'll go in and see if she's having trouble latching, or so that's what we try to do to get involved. But the NICU situations are challenging because they are separated.
Yeah, I think
Also
that's part.
educating CPS.
Yes, educating CPS too.
I've written letters for CPS workers, just outlining the benefits and risks of breastfeeding on MAT, and how strongly we encourage our mothers to breastfeed. And I've even had patients present that in the courtroom to the judge, and they've been able to bring their babies home specifically because they're breastfeeding.
Oh, wow.
Yeah, so I think just arming them with that knowledge is very important. Yes,
I really agree with that, is arming them with the knowledge and accurate knowledge and you know, and proof to back it up, I think has been beneficial. And that's a really good point. And we're trying to build a better relationship with CPS. It's so inconsistent sometimes across the board. And I think sometimes that's a barrier. But yeah, I think, and you know, I think some of the other struggle too is, you know, this baby did not score high enough to need any type of pharmacological intervention, and his highest scores were when he was removed from mom. And so even just sometimes having that conversation of, that's natural, like they're like, look at these scores, and I'm like, when was this? Like right when you removed him, like of course he's not going to be able to soothe and he's going to cry longer. So I think that's hard too.
Amanda, was this both, did you feel as though the barriers were both while in the hospital and then CPS, or was both, it was primarily the CPS worker?
I think it was both. I feel like it was both.
Yeah, and I think CPS education is so challenging because such a high turnover due to burnout and the systemic issues that are within that field. You know, we can have, I remember there was a period of time, and maybe it's a long time ago, but there was I know there was one worker that we had such great outcomes with around here, and then, you know, they've moved on to other things. And then you get the next one and, you know, everything goes the opposite direction. It's really frustrating just because you have to start with that education again. I know for some issues with like Project Hope moms, we don't hesitate to escalate it very quickly, which is not something we used to do, but I get our largest representative that we can, in our local agency. And I just keep saying, connect me to your director, or try and get direct cell phone numbers when possible, to sometimes really say like, here's the scenario. But the amount of staffing and manpower that would take for each case that I'm sure is sitting at our hospital right now is just unsustainable, the same as at yours.
Right. And you're talking about with CPS, you go straight to the directors. Yeah.
Yeah. I mean, I know a case that I'm thinking of, it was right after Project Hope opened. So we weren't like well established, you know, they weren't so sure. We have a little bit better now, but I literally, the on-call number just kept saying, I'm not talking to you. I want to talk to the next person up, because everybody had different opinions depending who we got on the phone.
That's helpful. Thank you. Yeah. Yeah, so maybe if we all can share those articles, sorry, Jay, to put that all together, but I think that it'll be great to have that to armor our patients with.
Yeah, no problem at all. Just send them to me and I'll get them in the recap email. So, you know, that'd be great.
Any other questions or guidance for Amanda?
Just solidarity and how frustrating that was. A case to listen to. I feel very angry.
Yeah. Thank
Same.
you. Thank you. That's validating.
It is, isn't it? The only other thing I might add, and you might have said this and I missed it, is I always ran into the Friday afternoon, I don't have a pump situation, which was a disaster for moms when, of course, that was the day they were being discharged and couldn't stay with baby, and hopefully that's happening less. But that's another great thing to add with your prenatal education, if you're not already, is look into a pump. And in the state, we work a lot with WIC, but we also really want moms to check with their insurance or their Medicaid. Technically, both private insurance and Medicaid are supposed to provide a pump. So we encourage them to check with them, do that ahead of time, because a lot of them require a prescription. which they shouldn't, but they do. And then secondarily, to be in touch with WIC, because WIC can be a source. It's just not every county the same and all. So we encourage them to go with their health insurance or Medicaid first. So absolutely. And we're going to share along with the resources something that's new and will hopefully be a better and better resource. It's called Zip Milk. And that is literally you at zipmilk.org, as in zip code, and you go there and you can put in West Virginia is now participating, and we're adding to our list of lactation support providers. It's everyone that's on there has to be trained. It's vetted and all. So it's growing. It's not where I want it yet, but in the meantime, it's a great source. You can literally put in yours, mom's zip code where she lives and find, within a 50-mile radius, folks that are trained. And I'm happy also to help people find folks, while we're still adding to that list, because that can mean a lot too.
I think that would be great. And that's the other thing too that was so frustrating is while she was fighting this, she continued to pump so that she had milk, and she had to get rid of all of that milk too, because she couldn't give it to the baby. And so she's like, I want to donate it. So she was just doing, and I think it's, and I'm really watching my language because I'm really trying to we had a training where I'm always saying like our women or my women. And it's so hard to not go back to that when you have situations like this where you just get so defensive and you get protective. So yeah. Well, thank you everyone for the resources. I'm excited. I'll be excited to go over them.
Thank you. That was a great one.
Yeah, I want to direct everybody's attention to the chat. There's the link for Zip Milk in there. Also have some solidarity, people who are equally frustrated with that case presentation. And then also a contact for someone who works with Unicare around these issues. Always helpful to have someone behind the scenes to help with these kinds of things. That's definitely something that if we're fortunate enough that our client's already engaged in prenatal care, we definitely want to make sure that she knows how to order a pump if that's something that she's interested in. All right. Any other questions or concerns, even outside of our case? All right, well, I appreciate your attendance, everyone. I'm going to hand things back over to Jay just for closing up shop.
Sure, thanks, Jennifer. Yeah, our next session is going to be on June 13th. So be on the lookout for the reminders and things like that. Please be thinking about submitting a case. We really appreciate anyone who can submit a case. Again, I think you saw with the past couple, they don't need to be, the encyclopedia of everything that's ever happened to this person. It's more of just, things we're struggling with, or you want advice with, or it could be something that is even just a policy or a practice question within your clinic. So please, don't be shy. And if you have any questions or you have any apprehension to submitting a case, please reach out and let us know. We'll work around that, because the cases are the most important part. Be on the lookout for emails, but I think that is about it. We'll have the slides, the recording for YouTube, and then I will wait for the resources from Molly and others to put in the recap. So the recap will be a little bit delayed, but well worth it, as we'll have a lot of resources in there. Lynn, I don't know if you have the link to the eval.
It's going to be late this week. Our project representative from Dania is out till Wednesday. So
Okay.
I have not gotten it from them. I followed up this morning, but I have an out of office till Wednesday.
Okay, so I think what we'll do then, if with that, so we're not bombarding you with different emails, we'll just wait until we get that link from them. and we'll send everything out at once for the recap of the session and everything. So don't worry if you feel like you haven't gotten it in a couple of days. That's okay. We'll get it to you this week.
And please, please fill out the evaluation. It's not very long, but it really does allow the Danny Institute, an out-of-state organization, to see the great work that's happening in West Virginia and to provide funding for ECHO.
Yes. All right, everybody. Have a great week. Great rest of the day.
Thank you.
Bye-bye.
Bye, everyone.
Thank